All right, so we're gonna go ahead and get started. So welcome to our first event of the semester. And today we're very happy to have Professor Ole Norheim. Ole has been a member of our community for about 10 years as an adjunct professor, and now we're extremely happy that he joined us full-time as the Mary B. Saltonstall Professor of Ethics in Population Health. So very briefly, Ole's work focuses on creating ethical frameworks for fair and efficient priority setting, with an emphasis on addressing inequality in low-income countries that are developing universal healthcare programs. Before turning over to Ole, I just want to remind everyone that all his remarks are based on his own scholarship and his own experience, and as such, he does not speak for Harvard. Ole, take it over. Thank you.
Thank you very much, Marcia, and for the introduction, and thank you all for coming. So I also included this, let me see, disclaimer here. I want to start with a story. On the wall of the Richard Dole building in Oxford, it's this slogan: "Death in old age is inevitable, but death before old age is not." And this is an idea that Richard Pito, the one to the left here, he worked with Richard Dole on documenting the effects of smoking. So he's been around for many, many years. Fabulous statistician. And this survival curve that you show is from his famous study where he followed British medical doctors, and they're looking at their smoking habits. And they documented that on average, smokers would lose about 11 life years. So Richard Pito always talked about the biggest risk factor ever, tobacco. But this saying has been a campaign for Richard Pito for many years. And the story I wanted to tell is that he was invited to Oslo a few years ago before the SDG targets were set. And he wanted to propose this slogan, halving premature deaths, as the SDG target. And the Norwegian government and people working on health in Norway were concerned about the SDG discussions being more and more expansive. And you know, it ended up with 17 targets and goals and 169 targets and a lot of sub-targets. And Richard Pito was concerned that instead of having like the Millennium Development Goals, very clear goals, and a few of them. So he wanted to propose that we should kind of put everything together in one goal. And the Minister of Foreign Affairs, they invited me to comment on Richard's work. And I had looked at mortality trends. I've been interested in that for years. And I argued that it wouldn't be possible by 2030 to halve premature mortality. So we started to discuss, and we started to write together. So he was invited to write an editorial for a global health issue of science, and invited me to draw the graphs, basically. So that's how we started, and then we started to, and we put a group together, and we wrote about whether it would be feasible to reduce premature mortality, the probability of death before age 70 by 40%. And we called it the 30 by 40 target. And we argued that that would be feasible. And now we see that there's less momentum around the SDGs than it was around the MDGs before 2015, for many reasons, of course. But Richard Pito hasn't given up this goal of halving premature deaths. But before I come to that, when we wrote and published this paper in 2014, we tried to convince Jeffrey Sachs, who was leading the SDG work. We even went up to Upper West Side in New York, his apartment. So we had lunch with him on a Saturday. and tried to convince him, but of course it was too late. So we were really not successful in our attempts, and we were also criticized. And that's what I want to talk partly about in this presentation. Critics have said that this target of premature mortality is ageist. So don't we care about those dying after age 70? So that's a criticism. And that's the question, can we defend it ethically, the target that we have proposed? So I'll return to that, but first present what we have done more recently on thinking about whether this is feasible or not, this target. So Richard Pito was invited to WHO in the fall of 2023, and he presented this idea to the leadership of WHO, including Theodros, and he reported back that Theodros was very interested in this goal because it could be aligned with the 100th anniversary of WHO in 2048. So we were quite optimistic that WHO would also adopt this as a goal. But we didn't succeed in that either, and I'll explain why later. So this is the kind of the research question that we had in the most recent paper. Is halving premature death by 2050 feasible? And if you look at this graph, so we use data from the World Population Prospect UN data. And if you look at the long trends, and this is the most optimistic picture you will see in the next few weeks. There's a lot of things going on in the world, in global health, in the US. But if we look at the long historical trends in health, there's been a lot of improvement. So on average, the probability of dying before 70. And that's, think about that. If everyone in the world could have that expectation, most of you who are in this room, you can expect to live until you're 70. But in some countries that have not been a reasonable expectation. So and we use 2019 before the pandemic as the baseline. So on average, the risk is 30% of dying before age 70. If that could be halved, we would be down at 15%. And that would mean that more than 8 out of 10 would have an expectation of living. So I think it's an interesting target. And if we look at the trends, it looks good. But of course, that's what we analyze more. So we published this paper in November last year, where we asked whether it's feasible to have premature deaths. And we use life tables from the World Population Prospects, and we only go up to 2019 because the pandemic changed a lot of this. And we do not look at the number of deaths. So we are not looking at rates. We are looking at the probability of death. Because the population changes, that would be a very different concept, and it would make it much harder. So we can discuss that whether that would be chosen. I don't want to discuss too much the limitations, but just mention that, of course, these life tables, for about half of the countries, they are robust. They're based on vital statistics from the US, from Europe, and so on. But for about half of the countries, we don't really have good data. They don't have vital statistics set up, so we don't know how many who dies in each age groups and so on. But the UN burden of disease study, others, WHO, they make estimates of mortality by age groups and sex based on surveys, censuses, and so on. But that's also mean that we are not doing a lot of kind of analysis of statistic analysis of the data, because if we are interested in explaining these changes, they might be the result of the modeling. So what we describe here is purely descriptive, and we should be careful with the interpretation. Okay. So instead of looking at all 193 countries or so, we selected the 30 most populous countries in the world. And we looked at trends between 1970 and 2019 in this graph. And you see that, again, a quite positive trend if you look historically at this. And I want to highlight a few of those things. There are some countries that didn't do well. South Africa, to the left here, of course, HIV and a slow political response to the pandemic in the 1990s and 2000s. They lost 10 years of life expectancy, and we saw that spike in mortality. Ethiopia, remarkable progress, except for in the beginning, where they had war and famine. So these large shocks will of course shape the trends in mortality. And in Russia, after Glasnost, they deregulated the alcohol politics, and especially middle-aged men had a very high increase in mortality, and you see that as these spikes in the graphs. And when Richard Peter present this graph, he talked about the sex, war, and vodka graph. That's the illustration. On the other hand, there are a lot of successful countries, and if you can avoid war and these shocks, we found in this set of 30 countries that 7 of these countries had halved premature deaths in 31 years. That's the same time period between 2019 and 2015. So it is feasible. So it was possible at least at that time. And we also see that, and overall in the world, we found 34 countries that have achieved this. So, and both from high mortality levels and lower. So we often think that low-income countries with high child mortality, they can achieve it. But I'm from Norway, but we actually found that Norway also had premature deaths from a fairly low level in the 70s. We see China. It's a little bit, we're cheating a little bit. So here was the war in 1971. So some of these steep drops are also because of that. But the general trend, when I first looked at South Korea, I thought it was a bug in the data. But they have had spectacular progress. So it's quite interesting. The same graph, but I've just kept the dots, of course, illustrates the inequality in premature deaths. And I think it's the concept of PPD, probability of premature death, is a nice way of capturing what we think of as an ideal, that everyone in the world should have equal chances to live a good life. But of course, when you see Nigeria with more than 60% probability of premature death, there is a lot of inequality in life chances as well. And this paper was also written as a background paper. It's Council Commission on Investing in Health called 2050. And we divided the world in 10 regions, a little bit different from the World Bank regions. And if we look here at, and this graph shows PPD in 2023. The North Atlantic region, we pulled out the US because they did so poorly. Stefan was never happy with this name of this region. But except for that, I think these are interesting regions to look at. And we see that PPD in Africa, Sub-Saharan Africa was 50%, 15% in Europe and Canada. But interestingly, the US, PPD was 22, and in China, 21. So if you think of that competition, it's quite interesting to see that the US have really slowed down, and the rate of change is not good at all for the US since 2010 at least. And here we see the trends for the 10 different regions. And we see there are inequalities in this pattern. Sub-Saharan Africa very high, but it illustrates that it might be possible to halve this probability of premature deaths. And this target is deliberately chosen to be a relative target. We could have said everyone should get to a certain level and have more absolute targets. That would create more equality. And some of the SDG sub-targets are absolute. But we have discussed that a lot, and we think it would be unrealistic to argue that Sub-Saharan Africa, given their high level of PPD, should be at the same level as Europe. But having a realistic but feasible goal is what we aim to do. So the graph shows that the dotted line is the current for the world in 2019. And the red dot is the target, looking at halving that initial level and by 2050 reaching that goal. So the argument, and of course it's based on describing these statistics, is that we also found 7 countries that when we looked at the rate of improvement in the last 10 years, 2010 to 2019, they had a fast enough growth decline to reach the target in 2050. So we see South Korea, they could actually, if they continued this trend, end up with 71% reduction. We see we have Bangladesh, Russia, Ethiopia, Iran, South Africa, and Turkey. Dr. Leah Tadesse, who is here, she was a co-author, and when I've discussed this with my Ethiopian colleagues, they are much more pessimistic, of course, because they have had civil war and other challenges. So even if the trend, maybe as a consequence of the focus of investing in child and maternal health in the early 2000s, we see the benefits now. So it doesn't mean that all of these countries will achieve this. So we need, and we discuss in the paper a little bit more in depth for some of the countries, whether this is really realistic. So these are the well-performing countries that have better than 2.2 average annual rate of improvements. These countries have between 2.2 and 1, so they're a little bit slower, but quite good, including China, Japan, and so on. And then we have the worst performing countries, where you see Germany 0.9. So they will not, if they continue the same trend, will not achieve halving of premature. So what we are arguing is that since some have achieved it and some are on track, it is feasible, but not for all countries. And they have to invest much more, change the health policies to achieve this target. And look at the US here. It's actually one, among these 30 countries, the only one with a reverse trend, which is, of course, very problematic. We also looked at, and I find this interesting, the rate of decline by sex or gender. And for most of the countries, the improvement is, the probability of premature death is lower for women than for men, but also the improvement is much higher for a lot of these countries. So it's interesting, and in the appendix we have more information by sex. So I think that's also interesting in looking at these trends. Why is it so that men are lacking behind? Do we focus too little on the risk, especially for early deaths? We know violence, work conditions, other things can affect premature mortality. So a lot of interesting things to be explored more. We don't say a lot about quality of life, chronic diseases. That is relevant, of course. Partly because Richard Peto is very stubborn and he thinks that mortality, we can count the number of people dying. That's uncontroversial, but measuring years lived with disability, giving a weight to this disability. So measuring chronic disease, it is harder. It's more a synthetic measure and less reliable, and we don't do it as systematically. So he was reluctant document trends and so on. And we know that it's from IHME studies and WHO, it's highly correlated. So this is just a graph showing the red line here is life expectancy, and the blue line is health adjusted life expectancy. So if we adjust for loss of quality of life from chronic disease, we see that they are quite well correlated. And the argument that we make in the paper is that if you look at the top 5 countries among the 30, the blue part of the column is healthy life. And the orange part is years lived with disability. So that's because you have some chronic diseases, back pain, everything, there is a loss. And we argue that countries that improve mortality so reducing premature mortality will increase life expectancy and thereby also healthy life expectancy. So the better performing countries, people living in those countries have more healthy life years. At the same time, you see the orange part is larger than for the bottom worst of the countries. So more people will be living for longer time with chronic disease. So demand for healthcare, end-of-life care, cancer treatment, cardiovascular disease will increase. But in general, it's highly correlated, and by reducing premature mortality, we increase the number of healthy life years lived. So to conclude this part before moving to the ethical part, we argue that it is feasible if nations that choose to do so, if they invest in healthcare. Some countries really need a lot of reform, but it is possible. 7 countries are on track among the 30, about 32 are on track if we look at all countries. So it's not highly unrealistic, it's aspirational, but we want to show that it is possible. So let me now move to the ethics discussion, and I bring this up because I think I'd like to work more on this issue, and I think it illustrates something about ethics as well. And that's, there are a lot of issues around numbers, about policies, how to evaluate policies that are technical, they are political, but they're also ethical. And in ethics, if there are legitimate, there are often legitimate arguments on both sides. So there's not one simple answer to this question. So I take this criticism quite seriously, and I'm bothered by it. And I'd like to understand more and defend my own views on promoting such a target. Because the people who criticized us, they argue that we are discriminating against people of old age when we propose a target where the world should just monitor and look at under 70 mortality. So let me try to defend it first. So we have 2 arguments in the paper. First, that the world agreed when they set the SDG NCD mortality target 3.4. So it's about reducing premature mortality in that context defined as mortality between age 30 and 69. Isn't that correct? Yeah. So there is an upper limit for that target. So that was one argument. The other argument is that the global life expectancy 2019 was around 72, and saving lives, younger lives, below average would both increase life expectancy and lifespan equality. So it's an egalitarian argument underlying this. We focus on the worst off, those who die early. And the inspiration for this argument is from a paper by James Wople, a demographer, that made a lot of impression on me, at least. It's from 2011. But they look at lifespan inequality, the difference in age at death historically, and they compare all countries in the world. And the key messages here are quite convincing to me, and they document it quite well, I would say. That most of the gains in life expectancy are the result of reducing disparities by averting premature mortality. So that, of course, you improve life expectancy and health more by focusing on early deaths. And progress in reducing death rates for people who live longer than average had little effect on life disparity levels. And that's obvious in a way. And they have a measure of inequality in age of death called E-dagger. And they estimate that a little bit below average or life expectancy, 2 or 3 years for most countries, there's a turning point. So if you reduce mortality before early deaths, you reduce lifetime disparity. If you reduce mortality in older age above the average, or approximately the average, you might increase lifespan disparity. So that's what they found, and there is a series of articles of this kind in the demographic. So, and the main conclusion here is that lifespan equality and life expectancy is highly correlated, and countries that have focused on premature mortality, reducing lifespan inequality, they have also achieved higher life expectancy. So it's good both for equity and improving the average, focusing on the worst off. So that is at least my argument for defending a target that it of below 70 mortality. It will reduce lifespan disparity, but also improve overall health. Another argument that we touch upon is that in global health, we have focused, for example, on under 5 mortality. And Bill Gates, that's his only target for health, or more or less. He is not interested in supporting global health initiatives for cardiovascular disease, diseases that cause death at higher ages. So, and the MDG target was very much around maternal health, but also under 5 mortality. And what we do in this paper is actually to move from that very narrow focus to include NCDs, because we see that a lot of low-income countries, the big burden now and the transformation they see is that more and more NCD deaths. And with this expanded target, we can capture at least up to age 70. So I think that's a very important positive argument here. Some have, when we discussed this paper, some argued that we should put the cutoff at 50 because that would favor low-income countries more. So we could also argue that we have put the target too high up. What would have happened if we had said, oh, we should care about probability of death before 80 or 85 or 90 or 110? We would end up with a target that would be meaningless, that wouldn't direct policies. And I think that the topic of the choice of target is also a priority setting exercise. It shows and tells country what they should prioritize to achieve the target, especially or if this is something that's agreed upon, that countries have signed up to, and that if they are held accountable. Okay, finally, back to the story why we were not so successful. So Richard Pito gave this talk where I had made the graphs, and Dr. Theodros was very happy with this. And they promised us that this would be integrated in the framework, this so-called 14th program of work and the statistical frameworks. And it is quietly integrated there. But we have also been told that this is technically feasible to start monitoring PPD, but it's politically difficult, of course, because it's ethically controversial. And I respect that, because people who are concerned about all stages of life, they might feel that they are left out by this indicator, or people dying after age 70. And the function of an organization like WHO is to advocate for better health for all. While what we have been doing in this paper and in our initiatives to kind of promote this target is to say that we need to set priorities. And I don't think that even if there is a target of under 70 mortality, that people will stop treating people at old ages, but maybe we should focus more about those who at old age, die young and early, and think about improving quality of life and other things for those elderly. But as you can see, this is a controversial topic, and I don't have all the answer. I'm not 100% sure that I'm right. So I invite a discussion. Yes. Thank you.
Right, floor is open.
Fantastic, thank you so much. A lot of food for thought. I wonder if you can comment on the composition of cause of death within this trajectory. So Bangladesh is going from 60 to 30, and that might be a completely different set of causes of death that are declining. Whereas Iran is going from 40 to 20, and then you want to go from 20 to 10. Eventually, I guess there is an optimal PPD where even the best performing countries have a 5-10%, and you can't do anything.
You can't do anything more, yeah. So we have a little bit of that, and there's a series of more papers coming now where we look at the decomposition. But in general, countries from a very high level of PPD, most of that was early death, child mortality. But increasingly, you know, the demographic transition and a big proportion of deaths, of probability of premature death is in this age group, 50 to 69. And a lot of them cardiovascular disease, some cancers, some other chronic diseases. So that will be made available. Yeah. And of course, it's not a linear trend. So we looked at it logarithmically, and it can't go down to zero, or probably not. But still, so the best performing countries are around 11%, and whether they can halve it, we don't know.
So there is a question online from Dan. Dan, you want to ask a question? Oh. Muted.
Can you hear me?
Now we can hear
Go
you.
ahead.
Okay, sorry. Thank you, Ole. As I've expressed to you, I just have boundless admiration and enthusiasm for all this work that you're doing with Trapito. I have one narrow question and then a larger one. The narrow question is this: it's been alleged that if you look for why it is or where it is that the West has been concerned with death rates in the third world, it's largely infectious disease because the West is afraid of those diseases coming to, infect them. And so there's underinvestment in NCDs because, that just doesn't affect how healthy people in the West are going to be. And so would it be fair to say that one effect of your proposal would be a kind of counterweight to that unfortunate pattern? In other words, I'm giving you an arguing point that this would help to correct for a pattern of underinvestment by the West in NCDs.
So my view is that I think countries need to finance, mostly countries need to finance their own health system. We will see a transition. We need development aid and so on, but we need that transition. So it's an issue of what to invest in. And I think when we see this demographic transition, we see more and more people dying of chronic diseases. The total number of deaths is going up. And this is simply an argument saying that whether you die of infectious diseases or of a heart attack is ethically equally important. Maybe age plays a bit of a role, But this judgment, and I was part of the NCD commission that Gene Buckman led, and he argued very strongly that the reason why we don't care so much about NCDs in the global health space is that we think of this as lifestyle diseases. It's up to people's choice and responsibility. And I think that's totally wrong. A lot of the risk factors are not about behavior. Some of them are, but a lot of them are not. And it's very hard to change behavior. And seeing women dying of breast cancer at age 55, I feel it's equally unfair and unjust as seeing a child dying of diarrhea, more or less, same category at least. So yes, I think this is really an argument for pushing the boundaries for what we should care about up to 70 at least. So that would be my answer.
I'll hold off on the second question until everybody else is theirs.
Thank you so much for this talk. So exciting that you're here. I have a technical workaround to the ageism argument that has its own implications, which you probably thought about, which is to think about the YLL, years of life lost. So wherever you can get gains, or YL is averted essentially. It could be younger ages where you have longer streams, but if you squeeze all that juice, maybe you shift to older ages, wherever it's feasible. Of course, this introduces new ethical implications, the lifestyle argument, fair innings could be a vote. How much did you think about that approach?
Someone said, a demographer, K-Fitz, said that all deaths are premature. And that's right. So even if you're 90, if you go into a life table, you have 6 or 7 life years. So all deaths are premature. So and YLLs are calculated by setting a kind of an upper limit, or it's based on life tables as synthetic life tables. So in a way, we should care about all deaths, of course. But then you have the fair innings argument, made famous in ethics, but also in economics by Alan Williams, yes. So this idea that everyone should expect to live the biblical 70 years, and if someone died before that, it's worse than if someone dies after 80. And it's a kind of widespread intuition, and of course this also informed our thinking, I would say. Yeah.
Chris.
Yeah, thank you for the talk. I was interested in the WHO part of the story. I was wondering if you've considered with them about sort of making the indicator more palatable. You could do the median, you could sort of be like 75% of people live more than 75 years, or like something to make it like slide in the back door if this is blocked.
Yeah. That's an interesting suggestion. When we discussed setting targets in 2014, Tore Godal, who's the kind of grand old man in global health in Norway, but working a lot in global health, he argued that at the political level, you need a target, a goal that is easy to communicate. And so halving premature deaths, everyone can understand it, but 75% percentiles or adjusting it harder. But it would be easier maybe to have it accepted. I agree.
Nick.
Yeah, so I think one way, and I think the way you sort of approach sort of justifying this target is in terms of how we might communicate it, or sort of arguments about what we value. But did you think about actually just going and collecting information from people on what they would value in terms of, if we're thinking about improving the health of people in communities around the world, like collecting data from people in communities around the world about how they value health? All right, I realize that in the past has got people things like delis, but trying to turn it into, like, I agree with you completely. You need a simple, really simple metric, but again, sort of taking that approach to reflecting the views of society rather than.
So we reviewed a lot of the literature on asking people about their kind of social preferences. So there's a literature on that showing that there a lot of studies showing that there is a preference for saving the young old. General tendency. Not everyone agrees. So there is a literature on that. But specifically on where to kind of calibrate the cutoff, we didn't do that. And I mean, I'm open to change that, and I think after 2050, that threshold should probably be higher because average life expectancy would be higher. But that's an interesting thought.
Okay, Dan, do you want to ask the second question?
You have to unmute.
You
And now,
muted.
yeah,
Okay.
I now have a third one too, but let me get to the second one.
Come on.
I'm going to insert a second one. So let me just share something because I can be a source of continuity in the field. I'll tell you a little anecdote that probably you don't know. This idea of fair innings, and especially the 70-year cutoff, the ghost of Alan Williams does hover here. This is what he talked a lot about, and he chose age 70 just like you are. I once heard Alan Williams explain where that came from, and I want to tell you what he said, because on the face of it, it makes no sense for Alan Williams. I mean, there's no particular reason to have any cutoff. You just go where the money will produce the most years of life. So why should you put less emphasis on post age 70 at all? And when he was challenged, he said, well, I don't know. I kind of felt seemed a little odd that we would say it was just important to get a 80-year-old to 82 as to get a 50-year-old to 52. And I saw that the philosopher John Williams had talked about something called fair innings, and he said it around age 70. So I just nicked that, he said. End of story. That's where it came from. It was there was a suspension of breath for a moment, because this thing which has global currency, and even people who don't realize they're quoting Alan Williams are, and maybe even you, and he admitted in that little moment that it was completely just an intuition, and he took the terminology and the year from a philosopher who, some of us know, John Williams, who was at Manchester. End of the story. So there's that little bit. Now, but here's the question.
I didn't know that, actually.
I know hardly anybody knows that, but I'm just telling you, it's all true. You can quote me. So just the main point I wanted to make was this. This is something you and I have discussed privately. It seems to me that WHO lost a tremendous opportunity when they didn't adopt this, because what it might also have done would be to encourage an international competition among nations to see who can get there fastest. And they could have leveled the playing field a little bit by sort of giving out points for those who are making the most rapid progress on their particular curve, because every countries that are where it looks hopeless, you can still applaud the progress they have made toward it. And to have countries compete for this, for lowering the probability of premature death, rather than GDP or armaments or anything, and so on, this would be a great vindication of WHO's mission. And if they could have grabbed any of the public sphere, public forum space, so that people's attention would be focused at least occasionally on how's our country doing in this, that it would have been a wonderful role for them. And it's just too damn bad that they wished on this one.
Thank you. I want to say, Dan, that we haven't given up. So we're still in discussions with them.
Michael, you have a question?
Yes, thank you, Ulla. Really interesting. I'm wondering if perhaps one of the reasons why WHO resisted this is not a question of ageism, but rather a question of those countries that appeared to be among the worst performers, i.e. the United States. And I was wondering if you had, in addition to a list of, ranking by worst, if the US was absolutely the worst performer in the whole world, that would, I would imagine that the US would not feel too comfortable with a ranking that makes them perform the worst. And I'm wondering what your thoughts are on that. I had a second question about whether you also did something on reasons for worst performers.
Yeah, thank you, Michael. I haven't thought about that, but might be part of the reason people don't like to be ranked, and we have been trying to be a bit careful, but we thought we should speak out on this because it's worrisome. Yeah, it might be part of the opposition. That is clearly an indicator where we know from Angus Deaton's work also that this deaths of despair, middle-aged men, and so on. So it really reflects that kind of development in mortality patterns in the US.
It might be
so that's-
interesting. It might be interesting in the US to do this by state.
So,
And to look particularly at, it looks like you've got Trump voters as the major problem here.
So Larry Summers, who was one of the co-chairs, he said that typically after these kind of global commissions, the World Bank, for example, would send people to Nigeria or Ethiopia to do a kind of deep dive into the country. So this time he wanted to have a US commission. So he's invited the Lancet Commission to do a US commission. And we plan to do exactly that, to look at PPD by state and by income groups and other things. So we are working on that.
And I would encourage you to look not just at the PPD measures, but to look at state policies that contribute to the premature mortality.
Yeah. Thanks.
Nick.
Yeah, so so you made the point, or made a rationale for leaving out non-fatal health outcomes, right? That your measure, or I guess if you compare YLLs to total DALYs, they're kind of the same. Well, you also said later on that we should use these metrics to inform policies, like to actually direct how we invest our time and effort. If I'm sitting in WHO and working in like mental health, like focusing on depression, I might interpret what you're saying a little bit differently. Like I completely buy that the contribution of non-fatal illness to overall life expectancy might be much, but depression adds very little to life expectancy, right? And so for those conditions where a lot of the welfare loss is coming from non-fatal illness, I could see, or I guess, did you get any pushback specifically from parts of WHO or other disease consortia where they felt they weren't going to be reflected?
That's a good point. So we had a lot of internal discussions. I actually think I'm used from Europe to work with priority setting, economic evaluation using quality adjusted life years, and it's become well established. So I actually argued for a much stronger focus on YLDs or chronic diseases for exactly that reason. We care about chronic diseases that don't kill. But as I said, Richard Pito is stubborn, so he didn't agree. The reviewers also came with that point, and I think that's part of the resistance. I had talked with them about that it could be integrated with health adjusted life expectancy. They have the data, so I don't think it's impossible. So I agree, but when to some of you who are younger here, writing these kind of papers, you have to make compromises as well. Maybe I shouldn't have done that compromise.
You commented about the challenge between PPD versus variations of age of death. And I guess it's linked to some of the discussions around the US population. Can you comment more on that? We had some coffee machine discussions about the variance between, the trade-off between mean and variance minimization or optimization. Yeah. Like what would be the consequence of some of these policies if they are increasing variation age of that? You said they are correlated, but I'm not sure how strong that correlation is.
So many people argue that we shouldn't be so concerned about the distribution of age of death because it's so highly correlated with life expectancy. So if we improve life expectancy, and Wolf's study showed that you decrease inequality. But he turns it around and he says, if we focus on reducing inequalities, we also increase average. And both statements are true, I would say. So this is kind of focusing on the worst stuff. And we are doing some work now with Sara Bolongaita, among others, and Stefan and Sara has published a bit on that, looking at the 20% of the population who die early. And you see a lot of change there, but among the 20% who live longer, that's much more stable. So I like this rephrasing that if we focus on the worst off, we reduce inequalities and also improve health overall. Sometimes there is a trade-off, but not necessarily.
All right, I'm sure the discussion will continue in the hallway. Did you want to say something?
Can I say
Yeah,
one more thing? I started by telling a story. So I just wanted to not tell the story, but let you know about this story in Financial Times today. It tells a story about HIV positive man, Sam Kelo from South Africa, who realizes that he will probably not get more ART drugs. He counts his tablets, so he has for 62 days. So I think this was a reminder that population health mortality statistics is also about individual lives. And because of the policies now being changed, there will be a lot of people like him. So I just wanted to refer to that story. Thank you.